Let's get into that. I want to talk a bit more about some of these questions. Very pleased to welcome the program here this afternoon to talk more about this issue. Dr. Raywat Deonandan is an epidemiologist and associate professor of the Faculty of Health Sciences, University of Ottawa. Thanks so much for joining us here this afternoon. Welcome to the program.
Thank you for having me.
As I say, we have the official death toll when it comes to COVID-19, which, as I say, is I think now around 5,000, so pretty significant. But why is it important to get a clear picture of what's going on in this country on this front?
Well, this is not so much a health crisis, it's a health systems crisis, and the health systems crisis is battled with numbers, with data. Unless we have good information, we can't tell the full extent of the epidemic, we don't know where to apply our resources, and we don't know how accurate our models are. So it's critical to understand where the disease is, how serious it is, and how many people it's affecting. Now, you mentioned in your intro that we're probably undercounting the deaths. Absolutely true. But a lot of the narrative coming out of more conspiratorial circles says that we're overcounting the deaths. So it's important, if for no other reason than to combat the conspiratorial narrative and to get a solid grasp of the numbers.
Right. Explain that a little bit more. I mean, it does seem strange to me, but as best I can understand it, I think there's a theory that, hospitals are just quick to ascribe any death to COVID-19, and that maybe some people are dying for some other reason, and it's just being counted as that? Is that basically it?
I like to use the analogy of HIV/AIDS. For the longest time, we didn't know how many people were dying of AIDS in the early days of the AIDS epidemic in the 80s because there wasn't a line on the death certificate to account for that. So people don't die of AIDS, they die of an opportunistic infection that's been accelerated by AIDS. Similarly, people don't really die of COVID. They die of the pneumonia or the heart disease or systems failure that's been accelerated by the COVID. So let's say you die of COPD, of extreme pneumonia, and you happen to have COVID. You died of this one thing, but was it the COVID that pushed you over the cliff? Sometimes that's a quality judgment by the physician that's signing the death certificate. So what a lot of places are doing, like the CDC, is saying if you died and you tested positive for COVID, we will count that as a COVID death. Now that is seen in conspiratorial circles as being a deliberate overcount to inflate the seriousness of the disease, when in fact it's an undercount, as you mentioned in your intro, because we aren't capturing that vast number of people dying in the community who we don't even know about.
And it's not data that we have access to yet in Canada, but we do have data from other countries, the United States included. And so it's pretty stark when you look at either last year or a rolling average of 5 years, deaths from all causes compared to this year. It's quite a difference, isn't it?
It's remarkably high. The CDC has a pretty good graph on their website showing what's expected and what actually did happen, and what are the deaths that did happen that probably weren't due to COVID. And the number of COVID deaths is quite stark. In fact, in some places in the world, it's estimated to be double the death toll. In Canada, I don't think it will be that bad because one of the factors that compels people to die at home is the inability to seek health care because they can't afford it. So socialized medicine, free medical care for all, is a disincentive to die at home without being tested. But it still happens. So in the early days of the epidemic, people were probably having what they thought was a bad case of the flu that wasn't being diagnosed, and they're dying. Keep in mind that the death counts, the official death counts, are only amongst those who test positive for the disease. We weren't testing everyone who was showing symptoms early on. In fact, we still aren't. So what the CDC has done, and some other countries as well, and some provinces, is if you show a number of symptoms that we think are COVID, we're going to assume that you have COVID even if we don't test you. And that helps to account for some of the data gaps. But it's not enough. We need to have this excess mortality approach to really get a solid sense of what's happening.
And at the same time, too, I mean, there's the question of how many people have had this. And the number of deaths obviously helps give us some understanding of either the case fatality rate or perhaps the overall infection fatality rate. But there's the other side of it, though, in knowing how many cases there have been and what the true infection fatality rate is. So how do we get a better understanding of that?
Right. So we're talking here about essentially dividing two numbers, the number of deaths divided by the number of cases. So you mentioned the case fatality rate and the infection fatality rate, and your audience sounds well educated to know that they're different things. The case fatality rate is the fraction of cases that we know about who die, and the infection fatality rate is the number of people who actually do die who have the disease that we don't even know about. So the best way to get the denominator to compute the infection fatality rate is a prevalence study, a random sampling of the population to test for the existence of antibodies. So that's been done in some places in the world, most famously in New York, and they found like a 14.9%, I think it was, prevalence rate, and that gave them an infection fatality rate of about 0.8%, I think, or 0.9%. So that large denominator will lower the infection fatality rate, but the increased numerator of counting the true deaths will increase it again. So unless we do both of those things, we aren't getting a proper sense of the scale of the lethality of this disease. So they're both critical to answering that question.
Right, and so certainly it'll give us a better understanding of what that fatality rate actually is. At the same time, in terms of, getting back to the question of would there be people who are not seeking medical care, who are dying at home, how are we missing those individuals, or what's preventing them from seeking medical attention? I mean, are those some of the questions that maybe this will help us answer, or at least maybe questions we should be exploring?
Oh, absolutely. This is a systems failure at many levels. So if we are discouraging people from seeking care and from seeking testing, then we might actually be accelerating their path to death. We need to understand that if we're going to fix the system. There might also be people who have chosen the palliative path. So if you're dying in a nursing home where you're already under palliative care and you happen to get this disease, we probably don't know that you should be counted in those numbers. Also consider that in an outbreak scenario, let's say an outbreak starts in a nursing home, and we discover that there are 3 cases that test positive for COVID, we're going to assume that everyone else has been infected. But when they die, we won't count them as COVID deaths because we didn't do tests on them, because we stopped testing after 3 or 4 because we assume they have it already. So that's the kind of procedural process that we seek to conserve our resources. We don't want to waste too many tests. We know they're going to be positive anyway. That, in fact, lower the data quality. This is an ongoing issue between resource conservation and improved data quality. And we need both of those things if we're going to get out of this, with our skins intact. So it's an opportunity for the administrators to throw money at the problem and to throw a lot of it at the problem. I've been saying for the longest time that the way out of this is to spend money and to do some good old-fashioned management. This is no longer a scientific problem. It is a management problem.
Well, what does that look like in practice, though?
Well, let's say that we aren't in a pandemic scenario, but one is coming. Then if we have the capacity in place to do a remarkable amount of contact tracing and testing as soon as the first cases arise, then we can identify all the cases quickly and isolate them and quarantine them and prevent outbreaks from becoming epidemics. That's the goal here. There are always going to be a handful of cases here and there. We want to prevent those handful of cases from becoming outbreaks and prevent the outbreaks from becoming epidemics. So unfortunately, that probably comes with some, denudement of our civil liberties to some extent with the contact tracing and things like that. But that's the price of safety in the era of pandemic.
Well, we see, South Korea is a good example of a country that's been very aggressive when it comes to testing and tracing, and they've been quite successful. But, even despite that success, now they've got this situation where one individual who had gone to a few nightclubs, it's now led to a few dozen new cases. So it can escalate quickly.
Absolutely true. And the positive of that story is that they were able to trace that person. And they were able to figure out which nightclubs went to. So imagine if they weren't able to trace that person, it would be completely out of control. So because they had the technology in place and the infrastructure in place, they were able to contain it, perhaps not as quickly as they would have liked. But we are not there yet. If that were to happen here, we're a little bit lost for what to do. So we have to move fast to get the infrastructure in place and to not just to contain the disease, but to feed the data nerds like me so that we can make the proper decisions and make the proper models so that we can plan better. This is very much a planning exercise, and planning exercises take good data.
Absolutely. Well, we'll see what that StatsCan data looks like and go from there. We'll leave it there for now, though. Dr. Deonandan, thanks so much for joining us here today. Appreciate this.
Thank you so much. Bye-bye.
All the best.